Awesome. Thank you, Rachel. And thank you to everyone for joining us today for MVC's Preoperative Testing Work Group. My name is Emily Bear, and it is my pleasure to be facilitating today's work group for you. Um, we've got a great presentation. All right, but just a couple of housekeeping items to go through before we get to our presentation from Henry Ford Genesys on their pre-op testing QI reduction plans. We'll then follow their presentation with a discussion and Q&A, and then some reminders about MVC's upcoming events and updates. So those housekeeping items. Before I introduce our presenters, just a couple of housekeeping items to review. First, this work group session is being recorded. The slides and the recording will be shared with you all following the work group. Just give us a little bit of time to pull all of those materials together. Second, a reminder to please double check that your mic is muted throughout the presentation to reduce background noise. Of course, unless you'd like to ask a question during that Q&A session following the completion of the presentation. Finally, we will be monitoring the chat throughout the presentation, so feel free to add any questions as they arise. We will then take those questions at the completion of our presentation today. For those attending the work group for P4P credit, we look forward to your active participation throughout the work group today, primarily through discussion and asking questions. We will share the post-work group survey at the end of today's work group. That'll be provided in the chat, but it will also be provided in the post-work group email follow-up. For hospitals participating in P4P who would like to receive credit for this work group, that survey is mandatory. And as a reminder, please note the hospital that you are attending this work group on behalf of so you can appropriately receive credit for your attendance. All right, so welcome to today's presenters. Megan Wadowski is a principal quality consultant with an extensive experience driving quality, process improvement, and operational excellence at Henry Ford Genesys Hospital. She's passionate about helping organizations solve complex challenges, foster a culture of continuous improvement, and deliver meaningful and sustainable results. Welcome, Megan. She's joined by Brooke Wagner, Clinical Quality Facilitator and SCQR. She's a dedicated healthcare leader with a passion for advancing quality care for surgical patients through evidence-based practice and continuous quality improvement. She serves as a collaborative leader and change agent, guiding initiatives across her health system that drive sustainable improvements, enhance patient outcomes, and strengthen organizational performance. So welcome, Brooke and Megan. They will be leading a presentation from Henry Ford Genesys Hospital today. So I will now pass that over to them.
Okay. Well, thank you for that introduction, Emily. We appreciate that. And thank you for the opportunity to present about our pre-op testing QI reduction today. All right. So getting started, recognizing that there was an opportunity for improvement for pre-op testing. So with this, MSQC had reached out to us and said, hey, your numbers are greater than 40% for pre-op testing for low-risk surgeries. So we'd like to give you the opportunity to participate in this. And we also got the opportunity to meet Dana from Right Size at one of the collaborative meetings and discuss with him what that would look like and some of the support that we would get with that and just the benefits that that would bring to our patients and our facility. So after reviewing that, I took that information back to our director, Sarah Johnson, and our surgeon champion, Dr. Chris Ash, and then also our chief of staff, who's also an anesthesiologist by trade, Dr. Danik. And they across the board said, yes, we have to participate. Dr. Danik has a huge background in trying to reduce this pre-op testing for low-risk surgeries, so it was an automatic yes for us. And our desired outcome with this project really is just to reduce that unnecessary pre-op testing and to also just better align with evidence-based practices and align ourselves with Henry Ford as we were merging two systems together. So our team members, myself being the SCQR and working with MSQC, and then Dr. Ash is our surgeon champion and general surgeon. Dr. Danik is our chief of staff and anesthesiologist by trade. And then Courtney Dickerson, she's the manager of PAT. And then Megan got to join us in the last few months as she took on the role as principal quality consultant. So with this, we got to collaborate well with the Right Size team, and they actually came to visit our site early on in March, April. And that site visit was very valuable to our team. It really brought together MSQC, MVC, our team, and really got the key stakeholders at the table of what is the intent of this project? Why are we doing this? How can we do this? And what are some of the barriers of this? And some of the key outcomes were that we got to look at just the organizational data, our current workflows. We identified that our site was operating on a outdated workflow that just happened to be something within our EMR. And that just opened up opportunities for us to be able to reduce that pre-op testing in our low-risk surgery patients. It was a great opportunity to discuss some unique barriers that our hospital has, and then just be able to share perspectives from nursing, anesthesia, leadership, and really be able to start those early discussions about how can we make action plans and different strategies that the Right Size team has seen work in other hospitals and things that they have seen not work well in other hospitals that are similar to ours. So our partnership with the Right Size team was very valuable. Dana and I met for coaching sessions bi-weekly. We're also just about to start wrapping up our interviews with Dana in the next 2 to 3 weeks with our team. And those coaching sessions were very informative, very collaborative. It was very much a conversation about after taking a survey and seeing from each team member where we thought some of our barriers lied, and just being able to get evidence-based practice and guidance about where can we focus at our site to most help reduce this pre-op testing in our patients. And we landed on education section or sessions, just increasing awareness, opening up those conversations, having opportunities for providers to ask questions and nurses to ask questions, because we've seen a lot of, hey, I've done this for 25 years. This is how we've always done this. Just giving opportunities and giving those opportunities at the proper time, not being at the bedside asking those questions, being able to ask the questions before we're in front of the patients, and not increasing any fear or any anxiety in our patients. And then we also are focusing on auditing and feedback. I think we all are aware that once we implement a change, it's very important that we follow through, identify fallouts, look at trends, and just continually look at, is our process working? Is there an area that we need to change to increase our process improvement? And then Megan, if you want to jump in here.
Absolutely. As part of our review of MVC custom report data from Q1 and Q2 of 24, we examined the preoperative testing rates with our Robotic Center of Excellence. The data revealed that historical preoperative testing practices continued even after we transitioned from the open hernia procedure to the robotic hernia repairs. While robotic procedures often require less extensive preoperative testing, established practice and patterns still remained in place. In early 2024, our preoperative testing rates increased nearly to 40%, which is slightly above the MVC benchmark. This increase suggested that legacy testing practices were still being utilized despite changes in the surgical technique and patients' needs. Since then, we have steadily declined from 39.7 to 31.8, and most recently to 30.6. The downward trend really indicates the progress towards more appropriate utilization of preoperative testing. Based on these findings, we provided education to the surgeons and clinical staff regarding evidence-based preoperative testing, the recommendations for robotic hernia repairs. The goal was to reduce unnecessary testing while maintaining patient safety and quality outcomes. In addition to clinical metrics, MVC data allows us to better understand the social and environmental factors affecting our patient population. Our review showed that many of our patients live in communities facing socioeconomic, challenges. Appropriately, approximately 37% of patients reside in areas with lower than average vehicle ownership. More than 40% live in a zip code with lower than state average income levels. Over half our patients come from communities with higher utilization of SNAP benefits. Nearly 2/3 reside in areas with lower home ownership rates. These factors can influence a patient's ability to access care, attend follow-up appointments, obtain medications, and successfully recover after surgery. Understanding these barriers helped us design care processes that were realistic and patient-centered. Based on the insights, we reviewed our discharge education process. We simplified and restructured discharge instructions to improve clarity and accessibility. We incorporated more patient-centered language and clearly guidance regarding follow-up appointments and recovery expectations. We also considered transportation and access barriers when developing education materials and discharge planning resources. Based on the insights, we reviewed our discharge education process. We simplified and restructured discharge instructions to improve clarity and accessibility. This work highlighted the importance of looking beyond clinical outcomes and understanding the social factors that influence patient success. By tailoring our communication to the needs of our patient population, we can improve patient understanding, engagement, and overall outcomes.
All right, and then after, oh, Emily, can you go back one more time? Sorry. After reviewing our MVC and MSQC data and identifying opportunities for improvement, our site did a major revision to our PAT guidelines for our low-risk surgery patients. Dr. Danik and Courtney, our PAT managers, spent many hours reviewing and revising the protocol that we have now rolled out at our hospital. The team made a plan with the right-sized team to make sure that the nurses get a chance to see this new policy in their orientation and that they have a chance to ask questions about the policy. Providing the right time and place for questions is essential to making policy changes. Making sure to encourage staff to please ask questions about policy changes and prior to being in front of the patient's room. Education and follow-up are key to adherence to success when making such large policy changes at our hospital. And then we identified our barriers. So it's no secret our hospital has a unique situation. Our staffing is fluctuating because our nurses are on strike still. So we do have a lot of agency or contract travel nurses, and they begin every Monday. So that has been a large barrier for us. We also have administrative associates that build the charts. And those associates can get pulled to different units every 4 hours. So making sure that they are also aware of the changes in the new paperwork that is going to be in these charts has been very important. Another barrier that we identified is that some of our surgeons and physicians are private practice and some are employed by the hospital, and that can cause a barrier as well. But some opportunities that we also identified in this are that we are getting Epic as our EMR system in November. We're all very excited about that. And we're hoping that will just help enhance our clinical decision making and help standardize the pre-op testing guidelines and adherence, and not having the physicians write their own orders for that, just really streamlining that ordering process and order sets. And then we also looked at future considerations with our providers, with some being independent and some being private practice, just looking how we can better our communication with them and just really educate the providers on our why and why we are pushing these changes and how it's going to enhance the quality of surgical care that our patients receive here. And then also just collaborating with other key stakeholders that aren't the surgeons or doctors, but those that are in our C-suite and that are helping to get us engagement and just helping to also drive the importance of reducing pre-op testing, and also making sure that we are doing ongoing monitoring. And we meet monthly about this and get feedback from our team. And we each take that out to different, Dr. Danik takes that back to his team, Dr. Ash goes back to his team. So really making sure that they're taking it back to their peers, and then we come back and any feedback they get, we discuss that and help push that out. And then lastly, if anyone has any questions, I do have an ending quote that I would like to leave you all with from Dr. Omar Razi. Sustainable change requires leaders who model continuous learning. And one of the biggest takeaways we have seen from this project year is the impact of leaders who model continuous learning. When leaders remain open to growth, collaboration, and new ideas, meaningful and sustainable improvements become possible. This commitment to learning fosters innovation, strengthens teamwork, and ultimately leads to better care and outcomes for our patients.
Great. Thank you so much, Brooke and Megan, for that presentation, and Brooke especially for that last quote. It's very impactful. All right, so now we're going to open up the floor to any questions or discussion that folks would like to have. I was keeping an eye on the chat, and I didn't see anything come through yet, but if you'd like to add a question, feel free to add that to the chat box. Alternatively, you can unmute and ask a question of our presenters live. Give you a second to consider. Well, Lisa commented that you're gonna really like Epic.
Yes, we are very excited about that.
Okay. Erica asks, did you have any issues with PCP ordering labs without being asked? I think you kind of touched on that a little bit there, Brooke, as that kind of being a barrier that you have some internal and some private practice providers.
So we did go ahead and meet with our PCPs early on in this process and just presented our why to them. And they actually haven't been a barrier in our process. I know some past sites that I've talked to through MSQC, they have been, but ours really have gotten on board with us and adopted these practices.
All right. Anna asked, what defines your low-risk surgical patients? is it procedures or medical history? At least from an MSQC and the right size perspective, they are a certain subset of what have been determined to be low risk surgical procedures. Um, so, as we're sort of outlined in one of those previous tables, I can pull those up here.
Yeah, those patients have to be it has to be an elective surgery, number one. An ASA has to be two or less. And for MSQC, it's cholecystectomies, hernia surgeries, some mastectomies.
Lumpectomy. Yep.
Yes, yeah.
Yep, and that is true for sort of the right size initiative, as well as for MVC's preoperative testing P4P measure as well. Those three, cholecystectomy, inguinal hernias, and lumpectomies are included. So I have a question for you guys, which is, I know I appreciate that you included some of the details from the MVC claims database report, which was sort of a part of your start with right size, and you showed how that supported sort of your intervention plans. I'm curious what sort of internal data you might be tracking or monitoring, especially as it pertains to things like patient experience. I know you'd modified a lot of patient-centered language and education and things like that around this. Have you been monitoring that at all?
So right now, the biggest things we're monitoring is the fallouts with the QI, what the day of surgery, when they have the day of surgery testing, what are we ordering, who's ordering it, and that involves tracking not only the surgeon, but we're looking at the anesthesiologist, who is the CRNA, what tests are done, why are they being done, and then Dr. Danik and myself review those cases every month. Especially if there's not a reason documented for those testing. And going back to that physician and saying, was there a reason? And if there is a reason, updating and making sure that's reflected in the charting. And that's been something new for our site for documenting the day of surgery testing. And we're also looking at the nurse, the pre-op nurse as well, and just seeing, are there any trends with who's ordering it or with the nurse, and just seeing if there are any repeats.
Gotcha. Thanks, Brooke.
Mhm.
All right. We do have a number of folks with us today, so I'm gonna do kind of an ad hoc poll question. If you can find the raise hand function, I am curious how many on the call today are actively pursuing some sort of intervention around reducing preoperative testing. Raise your hand if your site, if you are aware of the fact that your site is engaged in this work. Okay. All right. And then I'm gonna see, would one of you, there were four of you that raised your hands. Would any of you be willing to speak to sort of where you're at in this process? Are you sort of investigating opportunities for interventions? Are you actively implementing interventions? Or have you been doing this for a long time? Maybe Kelly or Rhonda, your hands are still raised.
This is Rhonda.
Hi,
Excuse me.
Rhonda.
Hi. We participated through MSQC, so that was our initiative, and our CRNA met with clinics and physicians and um, instituted a guideline to, and so that's still in progress. I was just scanning through our numbers trying to see how it's impacted. I mean, it looks like we're down a little, maybe 10%
Mm-hmm.
since that started. So it doesn't look like it's risen. I mean, we're working on other initiatives and I haven't kept a close eye on it, but it looks like our numbers haven't gone up since that time where we started showing some progress.
Gotcha. Okay. So kind of in a sustaining sort of phase right now, which is similar to Jennifer Dyke from ProMedica Hickman also called out that they were one of the very original pilot sites with Right Size, and they are currently in the sustaining stage. And then Kelly Steele also noted that they are working on interventions related to pre-op testing. Right. Kelly, would you be able to speak to like one or two interventions that you currently have in process? Or you can just chat them.
I probably couldn't speak as well as the rest of my team. I had just come on in my role as a patient safety officer as our team was starting to work on those.
Mm-hmm.
So I know that they were working on pieces, but I wasn't really involved with everything that they were doing because when we had our right size meeting, a lot of the things that they were recommending, we had already were in the process of putting those things in place.
Gotcha.
So we were kind of like ahead of the work already.
Awesome. Okay. Well, thank you so much for sharing, Rhonda and Kelly, as well as Jennifer, kind of your experience in this space. Do we have any additional questions for Megan and Brooke related to their experience? Right Size as a project is still recruiting sites. So if you are a site that um, has been contacted by Dana Green, with the Right Size project, and are interested in learning a little bit more, we'd be happy to facilitate a meeting to kind of walk you through some of those resources that Brooke and Megan spoke to. Okay. Well, awesome. I think we will then close out with a couple of notes on upcoming events. All right. So, we've got two upcoming MVC work groups, one additional Health in Action work group later this month on Thursday, August 27th. This will feature a presentation from DMC Detroit Receiving Hospital on their stroke program. And then in September, we will have a sepsis work group on the 15th. That will feature a presentation from McLaren Flint on their sepsis process. If you've missed any of MVC's recent work groups and are interested in kind of reading up on the highlights, we release a summary blog post outlining details and major outcomes of the previous month's work groups during the first week of each month. So check those out if you have not yet. All right. Some additional upcoming events coming to you. MVC is hosting its fall 2026 collaborative wide meeting on Friday, October 9th at Vistatech in Livonia, Michigan. The evening before that, on Thursday, October 8th, we will also be hosting a networking dinner. The location of that dinner is to be determined, but it will be somewhere in Livonia, close by to the meeting location. And then a couple of save the dates for upcoming 2027 collaborative-wide meetings. The spring collaborative-wide meeting this year will be on a Thursday, May 6th at the Treetops Resort in Gaylord, Michigan. And then our fall collaborative-wide meeting, we will be back on October 8th of 2027 at Vistatech. So we look forward to hopefully seeing many of you at these upcoming collaborative-wide meetings. MVC is also seeking presenters for the remaining 2026 work groups. We have a variety of different topics available. So if you are interested in presenting, please reach out to us. There's also a link there for presentation proposal if you already have an idea fully fleshed out. We're also collecting presentation ideas for 2027 work groups. So if you've got any ideas, feel free to reach out. All right, that completes today's preoperative testing work group. I appreciate all of your time. The link to complete the post-work group survey is going to be shared in the chat. Thank you, Rachel. As a reminder, if you are seeking P4P credit for your attendance to today's work group, please complete that survey. That is mandatory. And one survey, you may only complete a survey for one site for P4P credit. If you are not a P4P seeking site, feel free to also complete that survey. We appreciate any feedback that we can get. All right. Thank you again to Megan and Brooke for their presentation, and that completes today's work group. I hope everyone has a good rest of your day.